Good afternoon, everybody. Thank you for joining us for the next session of our Emergency Shelter Learning Series here at the National Alliance to End Homelessness. We're really grateful that so many of you have joined today, and we see some are still joining. So hopefully this will be a really good afternoon of content that you can use to help discover which rules are the right rules for your low-barrier emergency shelter. My name is Ben Cattell-Knoll. I'm one of the technical assistant specialists here at the National Alliance, and I'm pleased to be here joining you all today, along with some other Alliance staff, as well as two incredible presenters from who are running shelters in the community. So we look forward to hearing from them and hope that you all are able to learn something from them as well. So again, this is the second part of our Which Rules Are the Right Rules series. So if you joined us several weeks ago, we had two providers, one coming from the world of family shelter and the other from the world of the domestic violence shelter. So we learned how they looked at their rules and reworked them to lower barriers. And so now today we're going to be hearing about serving single adults in low barrier emergency shelters. Just a couple quick housekeeping notes. If you've joined us before, you've heard much of this stuff. As you know, we have many of you on the call today, so all lines are muted, but we do want to hear from you. We want to hear your questions. We want to hear your comments and your concerns and all of that. So please, at any time, if you have questions, place them in the question box on, it should be on the right-hand side of your screen in that little window there. There's also a chat box, but the question box is really a great place to put questions. We will try to get to as many of them as possible, but again, we have several hundred folks on the call today, so we may not be able to get to all of them, but we are hoping to compile all of these and put them into a frequently asked questions document at some point throughout this series. So please put whatever questions you have in there, and we will do our very best to get to as many as we can. Just also a note that all of these, the slides that you see today, as well as a recording of this webinar, will be posted on our website within a couple of days after this is done. So if this is your first in the webinar series, we welcome you. This is, I believe, our fifth now. So the previous four are all of those recordings are available on our website as well. And I will put the link to those in the chat box here momentarily. So just a couple quick housekeeping things. So the speakers today, as I mentioned, my name is Ben Cattell-Knoll, Technical Assistance Specialist with our Center for Capacity Building here at the National Alliance to End Homelessness. We're going to start by hearing from the Director of the Center for Capacity Building, Cynthia Nagendra, who's going to give us a brief overview of some of the keys to effective emergency shelter. And then our two wonderful panelists from the community, Kat Hammer, the Division Director for Homeless and Residential Services at the Lewis Center in Palm Beach County, Florida, and Liz Duffy, the project manager with the Downtown Emergency Services Center, or DESC, shelter in Seattle, Washington. So we look forward to hearing from the three of you today. So welcome, and welcome to all of you joining us. So we're going to kick things off with a poll. If you've joined us before, you may have answered some of these questions, but we just want to get a sense for who is joining us today and where your head's at in terms of thinking about how you currently feel about your shelter. So I'm going to launch this poll. A box should pop up where you have an opportunity to answer. So I'm going to keep this open for a little bit. So I'm going to try and launch the poll now. All right, are you all seeing the poll? So the question is, how are you currently feeling about your shelter and the work that you do? So select one of these. About 50% of y'all have voted so far. Let's keep it open for another little bit. Votes are still coming in, so I'll let the rest of those come in. About 10 more seconds. Awesome. So let's see. Hopefully these answers should pop up. Let me share these with you and see. Oops. Can you all see the answers? Oh, yeah, there we go. Okay, now, all right, now I see them. So it looks like a lot of folks are feeling like you're headed in the right direction. That you maybe still have some questions and could use some more help, but about half of you are feeling that way, and another decent number of you are saying we're doing all right, but we could use some further guidance. So hopefully we'll be able to have some of those answers for you today. Obviously not all of them, but we'll hopefully start to answer some of those. A few of you on here are doing amazing work already, and that is exciting, and we hope to hear more from you. And it doesn't look like anybody's feeling totally lost today, so that's we're all starting off on a pretty good foot. So thanks for that, everybody. And with that, I'm going to turn it over to Cynthia, who's going to start off our sharing for today. Cynthia.
Thank you, Ben. Good afternoon, everybody, and good morning, some folks on the West Coast. Thanks for attending today's webinar. So I want to start off by talking about why shelters are so important. And if you have been attending these webinars, I know that you've heard me say this before, but I think it bears saying again. And the reason that we've been having these series is because, shelters are extremely important, and almost every community has one as a response to homelessness. And sometimes it is sometimes a community's only or primary response to homelessness, or at least the one that's the biggest response, or the one that's been there for the longest. So shelters and other types of crisis beds are absolutely critical to the functioning of an effective crisis response system, because people who have housing crises will always need a safe and decent place to go. And without this, a community is really not able to make homelessness rare, brief, and one time. And all shelters in a community don't need to be low barrier necessarily, but every community needs some or a lot of low barrier shelter so that everyone has a place to go that needs a bed, and that shelters are not putting up barriers, or other stakeholders are not putting up barriers, especially if there are people who are living on the street or other places not meant for human habitation. And the reason is because they can't get into shelter, or they can't sustain their time in shelter because of rules or things like that. So we're really going to talk a lot about that today. And it's just clear to us at the Alliance how critical the work that you all do is, and how important it is to be part of a system response to homelessness. Next slide, please. So as Ben said, we've had a series of webinars, and it's really clear to us that we are seeing a lot of response from folks around the country, because it seems that people are very interested in this information and are asking for more webinars. So we're really happy to keep providing this information, keep having people from all over the country kind of inform our work. We know that what you're doing out there operating emergency shelters is extremely difficult, and it's often life-saving work. And the series here is meant to help you build on the very important work that you already do to respond to homelessness and shift practice in ways that will benefit people experiencing homelessness, as well as help your community take a real systems and housing-focused approach to providing emergency shelter services. So for those of you who are system leaders or funders, it's important to figure out what the role shelters play in your system is, and how to strengthen that. We also want to acknowledge that change is really hard. Doing things differently can be really scary. And we know that can take some time and some support to make that transition. That's partially why we're doing this series. We're hoping to help you provide that support. However, we hope you will hear about strategies and experiences from other shelters to make your work easier, more rewarding, and ultimately improve outcomes for people experiencing homelessness in your community. We've already heard from many of you that you're already seeing some positive outcomes, and we really welcome you to share any of that feedback. Some of you are sending us your changed rules, your improved outcomes. We're so excited to see those things and share them. So please keep letting us know how things are going. If things are going uphill or downhill, or however they may be going, we really want to hear about it. It really helps inform our work and helps other communities do better work. Also through this series are associated tools and guidance that you'll find on our website, which I'll show you a link to in a minute. We hope you get started. We're just really hoping to get you started if you haven't been making these changes yet, and if you are, really support you through the changes. You can also see that in in the box, sort of the panel has something called handouts. There's a handout section, and in that handout section are several tools that we have posted on our website that hopefully will be helpful to you. Some of them are infographics, a self-assessment tool. There are several more on our website. We can only kind of have a few handouts in the webinar because there is a limit to how many we can upload, but feel free to go straight from the handouts or go to our website. Next slide, please. So the goals really of the series are to help you all strengthen shelter policies and services to improve the housing outcomes, as I said before, for people experiencing homelessness across your whole system, to implement a system-wide approach to ending homelessness that includes emergency shelters and crisis housing. We want to align emergency shelters' goals with the community's goals to end homelessness, so we want to make sure that those goals all are the same, essentially. And we want you to help your community provide enough low barrier, safe, and housing focused shelter for those people who need it. And we're really hoping that the series is not just information for you all, but it's really hopefully guiding you to action and helping you accomplish these activities that we just talked about during the course of the series, so that you may build on the great work you're already doing. Next slide, please. The learning series on emergency shelters is, as Ben said, the 5th webinar in the series, and here are the other 4. They're posted at this link on this page, where you'll also find a number of our tools. Throughout the series, we've been talking about how to retool shelters by aligning your shelter with these 5 key elements. The 5 key elements to effective emergency shelters are having a housing first approach, practicing safe and appropriate diversion, ensuring your shelter provides immediate and low barrier access, making your shelter housing focused with rapid exits to housing, and using your data to measure your shelter's effectiveness and make shelter design decisions. Today, we're going to be focused on how to operate a shelter that has a low barrier environment, but still prioritizes safety for clients and staff. We really gathered most of this information, these 5 keys, from talking to dozens and dozens of shelters around the country in different geographies, serving different populations, and looked at things like who they were serving, how people were getting housed, how effective they felt their shelter services were, and really what their outcomes were. And we kind of saw that there were some commonalities between really effective shelters that were doing great work, and that's really where these keys came from. We're also working with several communities to kind of redesign their shelters and their shelter system using these keys and seeing some really great outcomes. If you want to hear more about our work or want to ask about how to do this in your community, please feel free to contact us. Next slide, please. So as we said earlier, today's webinar is really focusing on maintaining safety and having expectations and rules in a low barrier environment, and we'll be discussing the following questions amongst many others. Which rules, expectations, and guidelines are the right ones in a low barrier and a housing focused shelter? How do you continue to prioritize safety of shelter participants and staff in a low barrier environment? How can you ensure safety within shelters that serve single adults in medium to large congregate settings? And how can you help staff and other community stakeholders make this transition? We know that can sometimes be the hardest part, getting people on board with these changes that you want to make. So we'll talk a little bit about that today too. Throughout the series, we've been asking you where you find yourself on the scale of transformational change. I know many of you might be on the left side of the scale, starting to recognize a need and to change because of what you're doing. You feel like it's not working so well. You kind of know you need to make a change. It's likely that you will go through these various stages of change, especially staff who might be doing their shelter model for quite a while. You might feel confusion, anxiety, loss, and hopefully you're arriving at clarity. And hopefully it's not going to take as long as you think. So we have a poll about this that we want to ask you.
Yeah, so we're going to ask you those very questions to hear where you all are at today. So I'm going to launch the poll now. And so we're just going to ask, where are you in this process of transformational change right now? Are you starting to recognize the need for change? Are you feeling confused? Are you feeling that loss or anxiety that Cynthia talked about? Are you feeling that clarity? Or are you starting to integrate the change, starting to restructure? I already have a lot of you answering, or about a third of you all have answered already, so that's awesome. little over 50%, so I'll leave this open for about 10 more seconds. So if you haven't answered yet, go ahead and answer. All right. So I'm going to go ahead and close the poll. Again, it looks like so far many are feeling like you're starting to integrate and restructure and make some of these changes, which is exciting to see. A little more than half of you are feeling that way. But definitely some folks at all different various stages of change right now. Some folks that are really just starting to recognize the need for change, or feeling confusion or anxiety around making changes. But a lot of you feeling clarity, feeling a new vision, and starting to integrate and restructure changes. So again, thank you all for your answers, and hopefully there'll be something for each of you today in what you hear.
Yeah, thanks everyone for your honest feedback. For those folks who feel that they're not ready to change, or just sort of more on the beginning end of this transformation, if you want to contact us, you certainly put things in the question box, or contact us directly and let us know kind of what you're struggling with and why you might be having trouble, if you do want to make the changes and sort of are not able to get there, and maybe we can help kind of help you work through it. So one of the most important things we have learned from many communities is why people avoid shelters. This helps to inform how shelters should shape their environments to better respond to the needs of people experiencing homelessness. So this data on your screen is from a survey of unsheltered people in Seattle who are not engaging with shelter services. As you can see, 28% said there are too many rules. This is representative of other like surveys from other communities around the country. If you would like to better understand how people utilize or don't utilize your community's shelter services or your program's shelter services, we really encourage you to do a survey of consumers inside shelter and of people who are living outside that do not want to enter shelter, or say they do not want to enter shelter, or you feel that are more difficult to sort of engage and bring in. And it could greatly illuminate things about your shelter that you are not aware of. Oftentimes people are feeling that, people just don't want to come into shelter because they, quote unquote, want to stay homeless. And I think that we have learned through speaking with many consumers, and I know all of you who work with people, especially if you're doing outreach, know that that's often not the case. It's more that there's a lot of things that have happened that have made people not want to come inside, and that there's really sometimes it's programs and shelters that are the barrier. So we want to try to figure out from the consumer's perspective why this might be happening. We want to try to imagine how people who are coming into shelter are feeling, the stress related to crisis and trauma they may likely be experiencing, and how it really feels to be handed a long list of complicated and overly restrictive rules, or even just a lot of paperwork, or a lot of do's and don'ts when you're coming in from in the middle of a real housing crisis, and you may have been out there for a long time. So we kind of want to put ourselves in those shoes and see what that might feel like when we come into our shelter and look around and how we're engaged. In Seattle, if you want to know more about the Unsheltered survey, and this was more than 1,000 unique surveys, that shelter survey is on the Department of Human Services website. Next slide, please. One thing that I really want to emphasize, and I know our speakers are going to talk a lot about this today, is that low barrier does not mean having no rules. People often equate the word low barrier or the term low barrier with no rules, free for all, anything can happen. So I want to emphasize this very important point. Low barrier does not mean that there are no rules, and we will talk a lot today about what it does mean. So which rules are the right rules to have in a low barrier environment, and how do you retool your rules, your guidelines, your client handbooks, all of your written materials, everything on your walls, all your signage? Before we go into this, I'm going to turn it over to ask, I think we have one more poll actually.
We sure do. So we want to hear a little bit about what you all on the call, what your rules currently are. So I'm going to launch this and give a few options. So the last option is none of the above. So you can check multiple answers if there are multiple ones that are true. So do you require drug and alcohol testing or at entry, and or continued sobriety? Do you do criminal background checks for folks coming in? Do you require income or savings? Do you do bag or belonging searches? or none of the above. You're already low barrier. So again, you can select multiple of these if they're true for you. About half of you all voting, so thanks to those who have answered. More coming in, so I'm going to open this for about 10 more seconds. All right, so let's see. So it looks like about a quarter of you all listening in today do either require drug or alcohol testing at entry or continued sobriety, ongoing sobriety in order to remain in shelter. Similar number do criminal background checks as well. A few, about 16%, require income or some sort of savings for shelter. About half of you all do bag or belonging searches when folks are coming into your shelter, and about a third said that you don't require any of the above, that you are a low barrier shelter. So a nice mix of approaches today.
Thanks, Ben, and thanks for answering. I think that one thing, we'll sort of hit on all these points today, and I think what we're hoping you're doing with if you're there with your staff or at least in your office, that you have your rules and guidelines and client handbooks out in front of you, and you can kind of start looking through all of the sort of mentions of the things that sobriety rules, requiring income, requiring criminal background checks, things like that, and ask yourselves whether they're really necessary. That's what we're going to really ask throughout this webinar is, are these really needed, or are these things that maybe are you should consider changing? And we want to talk, our panelists today are going to tell you sort of about how to make those changes and how to respond to situations differently. But we really want you to kind of have your rules out, think about what you might want to change and why. So why do you have rules? Well, it seems that a lot of you and many people we talk to who work in shelters, for those of us who have worked in shelters and programs, rules are mainly about keeping people safe. That's what people often say, and maintaining a community environment that is comfortable, safe, and equitable for everybody. And oftentimes I think that's what the intention of the rules are, but sometimes that's not the impact. Many rules kind of create an unnecessary and often unintended barriers to getting in, staying in, and even getting out of shelter to a positive housing outcome. Sometimes rules can even keep people homeless. So we want to get rid of those barriers and still maintain a safe and decent environment. This quotation is from a qualitative study done on families staying in shelter that is an example of what parents in shelter sometimes feel, and I think it's just really powerful because it comes from a consumer that was staying in a family shelter. A shelter with too many rules can feel sometimes punitive and institutional. We hear this a lot in consumer surveys. And we want to ask ourselves why we would treat people experiencing homelessness any differently than anyone else. You know, do we think they did something wrong? Why does it make them feel like maybe they did something wrong? Or is it because we just assume having a lot of rules is good for everybody? We don't intend to make anyone feel watched or monitored, but we want to maintain an environment that's safe for everyone. So we want to ask, what if we approach the idea of rules in a totally radically different way and thought about what expectations the community should be setting for everyone to maintain comfort, safety, and empowerment? The key question you want to ask yourselves, are your program rules a barrier to accessing or staying in shelter? It might be helpful to reframe this whole notion of rules and reframe them as community expectations. This is a whole different ring to it. It feels less about compliance or about being punitive and more about the expectation of a safe and comfortable community environment. We've learned a lot from Ian DeYoung, so I really want to acknowledge him here and OrgCode. He's the CEO of OrgCode. I'm sure many of you have worked with him. He has a really effective way of talking about the role of rules that I'm going to quote here. Rules should promote safety. They should not try to change or control people or their behaviors, because people that we are working with are adults, and the job of shelters is not to try and change or control behaviors. Once you start to separate safety from controlling or changing behaviors, you might see your rules, client handbooks, and policies really differently. So if you're retooling the rules and you still want to promote safety, what does that look like? You want to focus on respect in behavior, not punishment for actions. Use restrictions and barring clients sparingly. Barring clients sparingly, and always connect people to alternative resources as best as possible. Know your own values and beliefs, but try not to impose those on others. That can happen a lot, especially if you've been doing this work for a long time. I know that when I was a case manager, I definitely felt that I had to keep checking in with myself to make sure I was knowing what were my values and really what I was imposing on others. And that kind of requires a lot of self-awareness and checking in with your staff. You want to accept people without judgment, treat guest belongings respectfully, try to encourage access to basic needs like hygiene with dignity and respect. We want to reinforce the strengths of each person and make sure that they are sort of building on those strengths rather than on their deficits. We want to talk about housing and community integration as much as possible. Housing really is the goal of shelter, and we want to make sure that that is very much a focus from the minute someone walks in the door. We want to be transparent in how decisions are made with guests, not about them. We want to circulate frequently throughout the shelter and actively engage with guests to encourage housing and promote hope. And we really need to be sensitive to the power of our position, even when we're just someone who is doing intake, or not that that's not an important job, but we have to remember that every position that we hold inside a program often is a position of power, right? Because we are the holder of services and supports, and we want to remember that. So are your rules trying to change or control people's behavior, or are they truly promoting safety? Do you really need these rules to maintain safety, or do they just give you the feeling of being safe rather than actually making anyone safer? Is it deterring people who really need your services from coming into your shelter? So look at your rules around sobriety, searching belongings, criminal history, weapons, curfews, tourist, case management, permanent barring, and ask yourself, what the rules are really for, and whether you really need them to promote safety, or whether they can be tweaked to sort of be less punitive and really prioritize people's safety in a better way. Another thing to think about: do you sometimes look at your rules and wonder where some of them came from, especially if you're maybe a newer staff person? You see kind of some really interesting rules and you're wondering, maybe they were there on the books for a long time and no one really knows where they came from. Or did you ever have an incident happen with a client that freaked you out so much that you made a specific rule to address that incident so that it would never happen again? Like maybe you had a person named Marvin come into shelter one night and he happened to have a lighter in the bathroom because he was trying to smoke a cigarette after curfew and he wasn't allowed out again. And instead he accidentally set the toilet paper on fire and you had a big problem in the shelter. So instead of telling people not to smoke, or maybe allowing people to go out to smoke at night, you banned all lighters and now search people's belongings for lighters. Well, we called those Marvin rules. And your rules sometimes, and often when we work with shelters, we see that there are a lot of Marvin rules. And it's really about one incident that isn't going to happen again, or doesn't really sort of promote the safety that you want it to promote. So take a look at your rules and take out the ones that don't make any sense outside of that one incident. So take a look at your rules, as I said, all your guidelines, your client handbooks, your written materials, all your signage, and ask yourself, and take yourself through these 10 steps. This is an infographic we created. You can download it from the handout section or from our website. So we want you to review incidents resulting in clients being barred. And I do want to say, actually, it was DESC, it was Liz and her staff that really gave us some of these ideas on how to evaluate our shelter rules and how to tell communities how to do this. So we just want to recognize DESC for helping us develop this. Review incidents resulting in clients being barred. Recognize similar issues that could be handled in other ways. Meet with staff and clients to discuss changing the rules and gather input. Review each rule for whether it helps people get out of shelter and into housing, or whether it actually inhibits that from occurring quickly. Get rid of rules that make it more difficult for people to get into housing. Drop rules that don't make sense, like those Marvin rules. Rules that remain should be directly related to safety, as we've said. And try to post those new rules and let them take effect quickly and see how they go. And hold frequent meetings with your staff and with clients to evaluate the new rules. If they're not working, change them. If you need to tweak some, that's okay. Make sure that this is a process that people have input into, and track if the number of people barred actually decreases. You might actually, hopefully, see some decreases there. This is an example from a shelter we have visited. They threw out their pages and pages of rules and put this up instead. So we wanted to just use this as an example that the new expectations can be pretty minimal and still convey that the community expects people to be respectful, responsible, and safe. If you have questions or you want to share your experience with us or any challenges and concerns that you have, please feel free to email us at the center at neh.org. We really want to hear how you're doing. And with that, I'm going to hand it over to Ben for another poll.
All right, fourth and final poll of the day, folks. So we are just interested in knowing, so a lot of you, I think, have been on, this is, either your maybe even your fourth, fifth webinar in our series, and so we're interested in hearing how you've used these webinars thus far. So I'm going to open up this poll, and we're going to ask, have you changed your rules since listening to this webinar series? So a couple different options. Either you've rewritten all of your rules, you've rewritten some, you haven't rewritten any because you were already low barrier, you're considering making some changes but want more information, might be why you're listening in today, or you're not really considering making changes because there's some lack of interest either from staff, from your board, from the community. Almost half of you have answered, so I'll leave this open for another minute. Give 10 more seconds for folks who haven't answered yet. All right, so it looks like we're kind of split in mostly into three parts here. Some folks have rewritten some of their rules and started to make some changes. Others have not yet, but are considering doing so and want a little bit more information. And about a quarter of folks are saying no, they already were low barrier coming in, so have not made any changes. And then a few here who have thrown out all their rules and started from scratch, and a few who are feeling like their community or board or staff is not quite ready to make these changes yet. So thank you all for that feedback. That's really helpful for us too, just to hear how people are using this information. So we really appreciate you joining us and hope these have been helpful. So with that, I want to throw it over to Kat Hammer from the Lewis Center in Palm Beach County, Florida, who's going to talk about how she has helped the Lewis Center transition from a high barrier shelter to a low barrier one. So welcome, Kat, and we look forward to hearing from you.
Thank you very much. Happy Thursday, everybody. It's my first webinar. I'm having kind of a panic attack. I'll break out into coughing, but let's hope that doesn't happen. If you'll switch to the next slide. I came to the Lewis Center in February of 2016. And when I arrived, it was a model based on social control and punishment and consequences. And in this time, we moved to a low barrier beginning in May. And we moved into a model that's about partnering and letting folks sort of lead their next steps. Can you go to the next slide? So the Lewis Center is a single adult overnight shelter. We have 60 beds. I know it's not a lot. We're the only shelter in Palm Beach County. We serve 40 men and 20 women. Unfortunately, we don't have shared units the way it was structured. I can't change the building. And we have 6 transitional beds, which are for emergency drop-offs from law enforcement or community partners who do outreach. And thank you. So when I arrived, again, a lot of this was, I'm not going to read all these things. I think you can read them. A lot of what was happening is the Lewis Center was a high barrier. No one could come in if they were using. They were drug tested. Everybody was. And whenever they suspected that someone had been using alcohol or drinking or using, they would get tested. People were required to go to AA meetings. They were required to attend life skill groups, but interestingly enough, these life skill groups were really focused on treatment, codependency, dependency, relapse prevention, etc. What I found is the vibe in the shelter was very tense, and there was a lot of tension, a lot of staff fighting, and a less focus on housing. We do have couples here, and they didn't want people to hold hands or sit next to each other. And if they thought you were using or drinking, if you wanted to keep your bed or come back, you'd have to go to treatment. Next, thank you. Ben. Oh, thank you. So the Lewis Center at that time would do something like a demerit system, a personal improvement plan. You broke a rule, you get a PIP, your case manager would go over this PIP with you, and you'd have to agree how you were going to change your behavior. And if you got three of these, you would get exited. And if you came high or drunk, you'd just be exited immediately. And when I first started at the Lewis Center, I'd come to work every single day, and I would get a written grievance from a client. The grievance was never about housing. The grievance the guest would write was about how upset they were that they received a PIP. And I found that I was spending a lot of time addressing this, and I came from a background of behavioral health with mental health recovery and youth development principles, and I feel like what we were doing is trying to control, not listen, and focusing on the wrong issues. The staff was spending an inordinate amount of time talking about breaking rules instead of focusing on housing. And our whole aim is to focus on, what is your housing plan? What are we going to do? What are our options? We got to stay focused. So the conversation that needed to be happening wasn't taking place, and the conversations around demerits were. Will you folks change? So I wasn't very liked in the beginning, which we'll get to about staff, but I came in February, and the old leadership had more of a social control model, kind of an old school way of doing things. And the first thing I did was get rid of the drug testing. I also stopped requiring anyone to go to AA or life skill groups. I stopped all rules related to sobriety, and the curfew is modified from early to 11 o'clock, and that's only so that people who are working can sleep because all the rooms are shared. Staff had an immediate response. I think I had some staff who were very entrenched in treatment modalities and the idea that treatment was what people had to do before they got housing. And I had staff person who said she would tell clients that they were here because they're alcoholics, and they were not at our shelter because they're alcoholics. They're at the shelter because they're homeless. Can you change? So after we got rid of all these rules, we have expectations. And really, primarily, the first and most important thing that we have a conversation upon entry, we have signs that say, what is your housing plan? So you got to have a housing plan. And in Palm Beach County, we have an interlocal agreement, and for us to open and be here, we had to make sure that people didn't bring drugs and alcohol on property. So we asked them to keep drugs and alcohol off property, which I agree with. We asked people to respect each other at 10 o'clock because some people have to get up at the wee hour to get up to go to work. And we don't have weapons on site for safety, though I do not have a metal detector, and we'd have to take someone at their word. And the other one is to treat people with kindness. So they used to have something also here, which I forgot to mention, which was required morning meetings, let's touch base, let's talk about accountability, sort of like a treatment center. And we did away with that. Now we have meetings occasionally just to do reminders that this is a communal setting. We all have to share here. I know it's difficult. We got to focus on housing. And the conversation is really about getting prepared for that, and it's not required. Next, please. And the first one is my favorite one. When I was moving this shelter to Low Barrier, I did have kind of a staff revolt with some folks. They were used and comfortable to having control. They kind of liked having the power. the say to whether who's going to come in, who's not going to come in, whether they went to treatment, whether they didn't go to treatment. And we also were a model where they were only accepting individuals whose VI SPDAT was between 4 and 6. And that leaves out a huge amount of people who need shelter, 7 and above, obviously, on the VI SPDAT. And it was this rigid. And we were not serving those folks. So I had a staff person who got very upset, went to my boss, filed a grievance, and wanted to have me fired. It didn't turn out that way, obviously. But people were kind of angry. Not everyone. I have to say that there was a very small turnover out of 45 employees. I got rid of a couple bad apples, which was about 2 or 3 folks, and I had a couple people choose to leave, which was wonderful. So we retained at least 38 people. The questions were, are you going to just let addicts stay here? What about their housing? They're high all the time, etc. And my discussion with people is whenever they say that, when you are wealthy or have money, you have a right to do what you want to do. If you want to be hungover at work, you're hungover at work. And no one stops that person. And we don't have a responsibility to control that. The responsibility we have is to have a conversation. If you're able to maintain, and if you want to use, that's your right. But you got to focus on what we need to do to get you into housing. And are you contributing to that? And again, I like what Cynthia said. This does not mean you let people just run amok and do what they want to do. This actually takes a lot of work. And people thought it's going to be a zoo. I think during this process, what would happen is what people found is they were spending less time fighting than they were, that it became more pleasant. It became easier to work with folks. We use a trauma-informed lens and assume that everybody has had some experiences and that we have to be prepared for that and be thoughtful. But that doesn't mean, just like with trauma-informed care, it doesn't mean there's no accountability. Next slide. So as I said, what we do now differently, instead of getting a person getting a demerit and then wanting to fight about whether the demerit, I didn't really do that, they just don't like me, etc. What we do is if someone has an issue and we see that they're high every day in the Serenity Garden and are not making movement, we'll have a conversation. We come in, one of the directors will be a participant, the case manager and the guest, and have a discussion about housing and how maybe some of the choices they're making now are going to affect their housing. So it's a very interactive, but it's not an immediate, like, you haven't done anything, you're out of here. We give people opportunities, but we have it throughout the process. We have open and frank conversations. We support them, try to get them connected to something if they need it, whether that be healthcare, mental health, behavioral health care, etc. But the aim is to have a conversation, hold them accountable, and then if we do have to ask them to leave, which I do often ask people to leave, is that it's not a surprise and it's not focused on the breaking of rules. It's really focused on, well, yeah, I see I made bad choices, and people get to come back. We have a very time-limited shelter, so people can, it's very, I haven't had anyone who's not allowed to come back at this juncture. So people can be exited, and when they're ready, they can come back. Next slide. One of my favorite supervisors, when I first started, said to me, Kat, I got a question for you. And he had a lot of questions for me, and every conversation we had was, I got a question for you, because he wasn't really buying into this, and he came from a long history of working in programs where everyone was required to be sober. And he was really worried about the drug tests happening and not happening, and it was going to go crazy, and had very little trust. And I said, you know, I've never needed really a drug test to tell me whether someone's high or using or drinking. And if I need a drug test, maybe, I don't know. It's not necessary to know. And he was like, well, what do I do if they come back and they're drinking and they're drunk? You have a conversation. Can we not be disruptive? Can you go to your room, maybe lay down? And if people are not being disruptive, it's not an issue. So a year later, after all these changes have happened, he no longer says, Kat, I have a question. He says, you know, I got to tell you. Kat, you know, I got to tell you that it's much easier working here. I don't fight as much. I have less stress. I'm not focusing on things. I'm actually having real conversations with people to support them in their housing plan. Because we don't want the frontline staff to feel like the housing techs and the supervisors who supervise the housing techs feel like they're having to police people. But rather, they also feel like they're contributing and supporting and helping people get focused on their housing. And I like the fact that it feels nicer. I think one of the things that I observed when I got here is that nobody spoke, and nobody spoke or greeted new guests. They'd be sitting on the couch, and people would just walk by as if there was a new person sitting on the couch. And we shifted the culture also to be one in which, you know, you say hello, you introduce yourself, you make people feel comfortable, and you begin the relationship then. And so that when you have to have a conversation because someone broke a rule or something's happening, or you're concerned about their stay, that you've established something. They know who you are. You're not coming at it as a punitive parent who says you're doing something wrong, but listen, I don't have a magic house in my hand or my pocket, so I need you to work with me. I don't know if I have, data slide, next slide. And I think a lot of times people are like, how are you going to do this? How are you going to get this done? You're never going to get these people housed, especially folks who have complicated needs such as mental health, substance abuse, and they're not in treatment, etc. You're never going to get them housed. And the interesting thing is that we had 418 admissions to the Lewis Center from October 1st, 2015, that fiscal year. And the following year, we had 447. We only rapid rehoused 76 individuals, and then this year we did 145, and this entire year we've been low barrier. And we've also served higher need clients because we no longer have a rule where you can only be a VI SPDAT 4 to 6 to come in. The assumption was that those other folks are going to be too hard to deal with. That's no longer true. We bring those folks in. I thought it was interesting to see that our average length of stay actually decreased from 56 to 50. And we, in our acuity list, we had a lot of people languishing at the top. People, as I'm sure everyone who's on this webinar, there's not enough permanent supportive housing beds. And they were staying on that list and not giving a chance to get rapid rehoused. It was a very wrong way to do. When we shifted that model, we've actually decreased the number of people with higher SPDATs and served more and got them placed. So it went from 75 to 36 this year. And Cynthia, I think I am done.
Thank you, Kat. I am going to save most of the questions for the end, but there are a couple questions that came in that maybe you could answer really quickly. Someone asked, how many direct care staff are working per shift in Palm Beach County?
At
the Lewis Center.
At the Lewis Center?
How many direct care staff are working per shift?
It's very small. So it's one per overnight. It's one for one in the men's dorm, one in the female's dorm, and one in the transition for 6. So it's 40 to 1, 20 to 1, and 6. And we have an overnight LPN. While we do not administer meds, she's here to ensure that people take their meds accurately because of our county rules. People can't keep their medications. They have to turn them in, but we don't administer it and we watch them take it. So a total of 5 people.
And that's really helpful to, I think, understand how things are staffed and what you need to have kind of, have those kinds of hours. How is your shelter open 24/7?
Mm-hmm.
Okay, and I think we'll probably want to ask more about how that works in a little bit. So thank you so much, Kat. That was really helpful, and we will have more time for questions for you in a little bit. And with that, I think we are going to hand it over to Liz.
All right. So just to provide a little bit of context around the services that are being provided in Seattle, hearing about Kat's shelter being the only shelter in Palm Beach really brought up for me some of the differences between our settings of where our shelters are located. So to provide some context, this year in Seattle proper, there were 4,665 people counted that were sheltered and 3,857 people counted that were unsheltered in a one night point in time count that occurred. And so the homelessness crisis in Seattle has been declared a state of emergency. It's a pretty big deal. And DESC is just one of the service providers that is participating in trying to address that crisis, both by providing emergency shelter, as well as DESC also provides permanent supportive housing, mental health and chemical dependency case management, and a variety of other supportive services. So first, I'm just going to give some background on the shelter program in particular, and then we'll kind of go into some of the rules aspects and the challenges that we face for that. So I'm going to focus specifically on our, we call it our main shelter. It's one of the largest single shelters in the city, and it's a 200-bed shelter for single adults. Another thing that struck me as Kat was talking is that in the shelter program, we do have a total of 338 beds, and our staff is about 40 people, which I think was around the number that Kat was describing for her shelter of 60. So the vast majority of shelter beds we're providing are not an enhanced shelter model. It's a pretty basic survival service model, where certainly our goal is to do whatever we can to move all guests into housing, but the level of service that we're able to provide towards that end is fairly bare bones. I'll talk about staffing in a minute. So we're a single adult overnight shelter serving people 18 and up, and we have a few eligibility criteria which can be seen as barriers. Really the only population that doesn't fit into that target population are men under 60 who have no disabling conditions. So if someone doesn't have any chemical dependency, physical disabilities, chronic illnesses, or mental health concerns that they either can tell us about or that we can observe, then we would refer them to other services in the community that are more focused on job acquisition, more focused on rapid rehousing and those types of things. Really our meat and potatoes clients are people that typically have multiple disabling conditions going on, so a major psychiatric diagnosis, likely some kind of physical or physical disability or chronic illness, and many also have chemical dependency. The physical structure of our shelter is that we have 120 beds for men and 80 for women, and all 120 beds for men are together in one dorm. For women, it's split up into 3 dorms just because of the space that we have. And as it says on the slide, clients self-identify dorm preference based on gender identity. And that's also something that can change from day to day based on bed availability, how the person's choosing to present. So we try to really follow the HUD guidelines with regards to that. And we're a 24-hour shelter, so during the day, which is defined as 5:45 a.m. to 4:45 p.m., we are open to anyone that's known to us. We have kind of a brief intake procedure to get people's basic demographic and identifying information so we can track their progress when they're using shelter services. So anyone that's gone through that registration process and hasn't been barred, we can talk about bars in a minute, but hasn't been barred for anything, can come and go freely during the day. And what that means is we see about 600 undifferentiated individuals per week coming and going from the shelter. So although we have a 200-bed capacity, there's both some turnover within those 200 beds of who would use them during the course of a week. And there's also a number of people that might only use the shelter during day services. They might come in to take a shower. They might come in to just be inside during the day. And they may either be staying outside and be unsheltered, or they may be staying at a different shelter in the community at night. Next slide. Cool. Thanks. So briefly about staffing. So at any given time, we typically have a 1:50 to 1:80 client to staff ratio. Sometimes that gets up closer to 1:100, which is obviously not what we're looking to have happen. And these are entry-level positions that are basically responsible for milieu management. So intervening when there is a medical emergency, when there's interpersonal crisis, and as well as meeting more basic needs like facilitating our meal service and getting people emergency clothing and things like that. So we have 3 shifts covering 24-hour operations, and that's typically the number of staff that we have present at our main shelter. It's 4 to 5 shelter counselors working per shift. someone might be on break, so we might have 3 on the floor. We also have some support staff that are present in the shelter during business hours. The mental health case managers you see on there are not actually part of the shelter team, but again, DESC is a really large multi-service agency, and therefore we are able to have some of our mental health case managers cited within the shelter, which is really nice. As it says there, one of the big challenges, I imagine for many of you, certainly for me, is high turnover among staff. And DESC has followed a low barrier and harm reduction model for a really long time. So I don't necessarily, and that's a thing that we are very transparent about during the interview process. And as you transition your shelter rules and policies towards a more low barrier approach, I really encourage you to be extremely transparent and forthcoming about that, addressing that really directly during the interview process, and really trying to assess whether your prospective staff, if you're hiring new staff onto your team, what their thoughts are and feelings are about that. There's also an aspect of people can express verbally support for certain approaches, and then the reality of that when they're working in the environment may be more challenging. So I think the high turnover that we experience is due to the low numbers of staff, or the high, client to staff ratio. That's really a product of the number of staff that we're funded for. It's also a very hectic, busy, and challenging environment to work in. And then DESC, being a large organization, also does a lot of promotion from within and wants to move people onto those entry-level positions into case management positions and other opportunities as soon as we can. So I think that contributes to turnover as well. Really what that impacts the most, though, is the level of training that we're able to provide to staff. Because one of the key things that I want to talk about, I guess you can go to the next slide. I don't know if it's on the next slide. Yeah, well, sure. So the last, I'll go through this, I guess. So all staff receive a week-long orientation. That's true of everyone at DESC, goes through the same week-long orientation. Among the topics that are included are CPI, which is the model of crisis prevention and response training that we use at DESC, CPR training, naloxone administration training, which is Narcan, if you've heard it by that name, reverses opiate overdoses. So all staff are trained in that, and all of our sites have naloxone on site. And then there's also, shelter-specific training that we do with all shelter staff. And I think when thinking about, this webinar is about rules and retooling your rules and deciding what rules you need. And I think, although it's a little bit less concrete, an equally important piece of the picture is how your staff respond when rules are violated. Because no matter what your rules are, rules be violated. And so what actions are taken, not only what rules are you presenting to your staff and to clients, but what actions are taken by staff when they're faced with a situation where a rule has been violated. So does that result in a bar? Is that at the discretion of the staff member? How does the staff, if it's at the discretion of the staff member, how does that staff member navigate that decision about whether this is a circumstance where a rule violation should result in a bar and when it shouldn't? And I think that is one of the challenges of having high turnover, is helping people develop those critical thinking skills and helping them make their own informed decisions about how to, I don't want to say exactly interpret the rule, but how to respond to rule violations when they happen. So a little bit about the kind of rules and barriers that we have at DESC, that checklist or that survey, that poll that folks took, all of those are things that are not barriers at our shelters. So despite having a 200-person shelter that sometimes during the day might have 250 or 300 people in it and has about 600 different individuals coming through each week, we have no security guards at any DESC site, either employed by DESC nor by an external agency. We don't have metal detectors, wanding, bag screenings, similar to what Kat was saying. We have a rule against weapons. But when we're talking about, shelter rules, we have a rule against weapons because that is a good, if we have weapons that are coming out in the shelter and causing problems, it's really important to us that we be able to set firm boundaries around that, because that is, of course, a huge safety liability, which is why we have the rule. That said, I imagine that if I were a person experiencing homelessness, I would probably carry a knife with me for a variety of reasons. And ultimately, if someone has a knife in their bag so that they can cut their apple or so that they can defend themselves if they have to end up sleeping outside, that knife in that bag doesn't necessarily make the shelter that much less safe. And I also would encourage people not to think that if you have a metal detector that you are therefore safe. I've seen all kinds of things that aren't quote unquote weapons be used as weapons, canes and chairs. And there's, if someone wants to hurt another person, they can probably find a way to do so. So I feel like prohibiting people from bringing, although we do prohibit people from bringing weapons into the shelter by not searching people or verifying whether or not they have the thing, it really reduces the number of people who are not going to come in at all because they don't want to have to give up that knife and then get a new one. So really what we focus on is what's happening in the moment in the shelter. I think when we think about rules, we really want to think about like, what is the actual behavior that we're seeing in front of us as opposed to what we're afraid might happen or what the reason for that behavior is the behavior acceptable and appropriate or not? I don't know if it's helpful to go to the next slide. But... Sure. So I think one of the big things that comes up with regards to low barrier shelter is the issue of substances, client intoxication. Of course, there are other sticking points around low barrier shelter, but I think that substances is a pretty big one. And really, that goes back to the idea of the behavior that you're seeing versus the reason for it. Kat was alluding to this. If you can't tell if the person is intoxicated without doing some kind of test, breathalyzer or something like that, does it matter necessarily whether the person is intoxicated or not? It might depend on, it might be something to talk about what the person's goals are. If there's someone that's trying to be abstinent, talking to them about that. If that's a goal that they have and then they're not meeting that goal, that might be a conversation. But does the person necessarily present a risk if their level of intoxication can't even be told, you can't even tell by looking at them or interacting with them? And actually at DESC, we go a step beyond that. So we do allow people within the shelter with varying levels of intoxication, even if it is clear to us that they are high or drunk on illegal or illegal substances. We do allow them into the shelter. Really, our only requirement there is that they, it's the same requirements we have for everyone, no matter what, that they be able to take care of themselves. So we need people to be able to get themselves from point A to point B and toilet themselves independently. So someone can't be, for example, so drunk that they can't walk or can't use the bathroom. That is a safety hazard for everybody. But that's true whether that person is having that experience because of medical conditions. We're not able to provide a level of care that would allow someone to be in the shelter safely if their medical condition is such that they can't toilet or ambulate themselves independently. And likewise, if someone's not able to ambulate or toilet themselves independently because of intoxication, that intoxication is too acute for the shelter setting. And so we're going to try to divert them to the hospital if necessary, or in Seattle, we have access to a sobering facility where people who are extremely intoxicated can go. But really, that's not about whether or not the person's intoxicated and whether we're okay with that. Really, that has to do with the behavior that we're seeing, that person's ability to care for themselves isn't congruent with the level of care we're able to provide. And so it presents a potential safety hazard for that person or other people. Likewise with kind of acting out behavior, people instigating fights, people being verbally abusive, those types of behaviors are challenging and often not okay. And that is true whether the behavior is because of someone's mental health condition, because they had a bad day, or because they're on meth. So we really try to look at all of those situations the same way. Is this behavior sustainable? Can we deal with it without asking the person to be outside? And if not, we may ask the person to leave. But if we can deal with it inside in a way that's going to allow that person to maintain shelter, that's what we're going to do. And we're going to try to take that approach, whether it's the behavior, no matter what we think the reason for the behavior is, or whether we don't know. So as a result of that, one of the things that I often have to talk to clients about, actually more so than my staff, because again, I front load this being a really central part of our mission really heavily when I'm hiring staff, when I'm interviewing them, when I'm onboarding them. I really, really heavily front load the low barrier aspect of what we're doing. But I do end up hearing concerns from other clients about things like the hygiene of other people who are using the shelter, since we don't have barriers around client hygiene, around substance use. So people that are having difficulty because they have observed someone that's high or drunk, or perhaps even using in the shelter. And I've just had to practice my ability to explain to other consumers of shelter services what part of DESU's mission is to try to provide shelter to all people. And that part of that entails providing, having an environment where things might not always be comfortable for them. And that's difficult. You know, I don't want to tell people that they have to be in an uncomfortable environment just because they're experiencing homelessness. I don't want people to feel punished just because they're experiencing homelessness. But I try to often draw the distinction between safety and comfort, because I think that that's one, a lot of times I'll hear about behavior that has made another shelter guest feel uncomfortable, and they'll frame it in terms of that behavior making them unsafe in the shelter. And one of the things that I really try to do both with staff and with clients is to separate those two phenomena, safety versus comfort. Comes up a lot around issues of transgender people and other people elsewhere on the gender spectrum using different dorms, where I'll hear someone tell me that they don't feel safe in their dorm because of the appearance of someone else that's sharing the dorm with them. And I try to kind of reframe that in terms of, I totally hear that that makes you feel uncomfortable. And if that person behaves in a way that puts your safety at risk, for example, if the person is threatening towards you, if they assault you, if they are engaging in other behaviors that wouldn't be okay for anyone to do, you know, that is something that we will absolutely address. Unfortunately, in this shelter environment, we're not able to address the fact that that makes you, we're not going to address the fact that that makes you uncomfortable. We can talk to you about it, but we're not going to address it by removing the uncomfortable trigger. And that's a hard pill for a lot of people to swallow, and understandably so. But I think really the key there is that people that are experiencing fewer barriers are typically the people that are struggling with a low barrier environment, and they typically have more options. We're still actually in a society where there's a lot of mixed shelters providing services in a lot of different ways, and so they continue to be high barrier shelters that are run by a variety of different types of service providers and religious organizations and things like that. So in our current landscape, there are a variety of kind of types of shelter that are being provided. So I try to be really transparent, not only with my staff, but also with the clients that are using the shelter, that we are a low barrier shelter that is part of our identity, that's part of the public service that we're trying to provide. And we want safety for everybody. But if that person is sufficiently uncomfortable in that environment, that they want to explore other options, that is certainly something that they are welcome to do. And if they continue to stay in our shelter, we will continue to do whatever we can to support them in moving towards housing, to support them in coping with the often triggering environment of being in the shelter, and then we're still there for them, but that doesn't necessarily mean that we're going to add a Marvin rule or add restrictions based on particular situations or particular concerns that are brought up. I don't know if I have any other slides or anything else to say. Do I have any other slides? Oh, yeah. So a few specifics. So as I mentioned before, security screenings can create a false sense of safety for staff. So, really, I want my staff to be helpful and approach clients and engage with them and not be hesitant about that. On the other hand, I want them to be aware of their surroundings, about their physical distance with someone, particularly if they're agitated. And I want them to be thinking about that with in the back of their mind, the fact that that we don't screen people's belongings when they come in, and they should just be taking appropriate precautions while trying to interact with that person as effectively as possible. One thing that I always advise my staff to do is, if we're calling 911 and asking for a police response, which we do, At times when there's any kind of physical situation, we are a hands-off agency, so we don't provide any kind of physical interventions if there's an assault underway or things like that. So if we do call 911, there's always a question from the dispatcher, are there any weapons on the person, or does the person have any weapons? And I always instruct my staff to answer, not that I know of, assuming they're not seeing anything, because just as I don't want my staff to go into a situation assuming that there's no risk, I likewise don't want police to go into that situation having been told by us that there aren't any weapons in this part of the situation when it's possible that there are. Another piece of advice that I give to staff is to avoid using the word bar. We do implement bars, and they're never permanent. The vast majority of bars from service are one-day bars. So the idea there is just that that person being in that environment right now is not working. And so we need to do something different. And that might be asking that person to be out of that environment for the rest of that day. When a more serious event happens, we follow a model where there's a committee that reviews the bar. The person comes and we talk to them about what happened. We try to see if they have any insight into what happened or if they can identify things they could do differently next time. And then we give people many chances. But in my estimation, finding different ways to frame our desire for compliance from clients, other than if you don't do this thing, then you will have a bar, tends to have a more productive and ally-based approach. So yeah, I think I am starting to go over time, so I'm gonna just stop for now.
Thank you, Liz. That was fantastic. And we have so many questions for both of you. I know we don't have that much time to answer them, but if you both don't mind, I have some questions. There's one question I want to ask you that is sort of a more common question we've gotten. And we did a survey of attendees over the last few months and asked them kind of what their challenges were and what their common questions were. And so there's a question that we've been getting today and in the past that I thought maybe you both touched on it, but I was hoping you could address. And that question,
who do you want to?
Oh, I think it would be great to hear from both of you. So maybe first Kat and then Liz, or and I'll sort of see how. I think you probably both have some thoughts on this. You both touched on substance use in the shelter. You're both working with people who are using substances. You both talked about how to think about that and how to help your staff think about that and approach those situations. And we get this question a lot. We've gotten it today. How do we help people who are trying to stay sober while allowing people who are under the influence of substances into the same space? Isn't that going to be a trigger for people who are trying to stay sober? How do we really keep people safe when some people are intoxicated in a congregate setting? And I think one of the questions here too was sort of how that people sort of feel that they're working on their sobriety and they don't want to even come into shelter because they hear that there's so much drug use and going on in the shelter. And kind of how do you think about that? So Kat, do you have some thoughts?
Sure. I actually don't. I think it's made it less difficult. The interesting thing about this whole sobriety question, the only time it ever comes up with other guests, 90% of the time, 95% of the time, is that they're being asked to leave because they have failed to engage or not be active or help us work on the housing plan. And they say, well, you let all these drug addicts and alcoholics in here. And it's interesting, that's when the issue comes up. And what I have found is that most people, when we do have a conversation, let's say you came in, drunk a couple times, it's kind of disruptive. Again, we ask people, or they're high. We've asked people to point out, like, how is this getting your housing plan? Like, if you can focus on all the things you got to get done, it's not an issue, but how's it getting in the way? And, I've actually seen people, they don't stop using, but they use less. And I really have not had conflicts where people don't want to come in because people here sometimes use, and I really don't have, I feel like that's our issue. I feel like that we get freaked out. And the truth is, I think one of the biggest triggers in the world is being homeless. And I think when people have a bed, sometimes that decreases usage anyway.
I have a couple thoughts as well.
Yeah, please go ahead.
A couple thoughts as well. One is that didn't see that response on the list of in that survey that you sent out at the beginning, Cynthia. And I really think that is telling. What we're hearing, I think my experience is that I hear from a very small group of people that they object to sharing a space with people that are using or under the influence, and that is a important and valid voice and message that I hear from those people. That said, when we look on a population of people experiencing homelessness, substance use and intoxication that occurs in shelters is not a barrier for other people accessing shelter on the same level as many of the other things, including too many rules. So I would say, we're kind of looking at for each individual person, unfortunately, especially if you're running a larger shelter, you're not able to provide the environment that's going to be most conducive for each individual to move out of homelessness and into housing. So how can we provide a space that's as conducive to as many people as possible? I also think that there's totally a role for clean and sober spaces and programs. I just don't think that should be kind of the norm and the majority of the services that are being provided. In fact, most people that I know are not completely sober. They're not practicing sobriety, and most people in our society are not completely sober. Most people use alcohol on a regular basis. In Seattle, a lot of people use marijuana on a regular basis. And so providing, making the homeless shelter, the majority homeless shelter system reflect really what's a minority in our population. When we want to be supportive to those people, it doesn't necessarily equate for me to push to have the majority or most, really any, but I would say that's more of a niche service that should be provided rather than the low barrier shelter being a niche service that's being provided. Really quickly,
can I jump in?
Oh, yeah.
I'm sorry. I do want to say again, I think what I noticed that you said earlier, and I think that's the consensus, is that it really isn't something that comes up all the time. It really comes up for the staff more than the guests. Honestly, it truly does.
I think that both of what you have said is so incredibly helpful. I'm writing it all down so I can answer that question exactly the way that you both answered it. And I think that it's extremely helpful. One thing that I have also heard a lot of is from staff and even from drug and alcohol specialists and counselors is that shelter folks might think that they are keeping people sober, but really that's not what shelter is for. As both of you have indicated, it's not a treatment program. If you're trying to be a treatment program, you're not really providing kind of wider shelter services. And the idea that people want to work on their sobriety means that they should be working, that's what they should be doing, strengthening their sobriety and doing that in a way that gets them, they have support that they need, but not expecting sort of the shelter to sort of be that environment. And I think that is everything that you've said has just really underscored all of those points. So thank you. So I have a bunch more questions, if that's okay, and I'll direct them to either Kat or Liz or both of you, and depending on what the question is. So one of the first questions, and so I have to say a lot of folks have asked for both of your shelter rules and expectations and what they look like and whether you're willing to share them.
Yes.
Yes.
I don't have them right here.
I don't have them on me, but I can send it for you to put up.
That'd be great. If you could share them with us, we would love to be able to do that. Someone wanted to ask, or someone has asked, when you do bag screenings, what does that really look like?
Like,
I don't know.
You're talking about looking through people's items?
Yes.
It's not, it is one of the things that we have conflict with. Again, we have a very strict interlocal agreement. So we try not to bag search all the time. And occasionally it's done. And all it is like open your bag and like you do at the movies, at least in New York, in case you had a weapon. Do you have something? And then you shut it and move on. That's all it should be. We do not want every time someone comes. We do not check into their items. I don't know about you. It sounds like you guys don't.
No bag searches of any kind.
No bag searches of any kind. Okay. So someone asked, how do you ensure, so this is, you touched on this a little bit, Liz, when you were talking about people who might, I identify, who are identifying as one gender, but people might be feeling uncomfortable with them in the same dorm, and how you approach that. But I want to ask a specific question somewhat related to that, and see how you'd respond. How do you ensure the safety of female residents who are victims of domestic violence when men who identify, quote unquote, as female to be housed with women?
The same way I assure the safety of women staying in a dorm with other women. I guess I'll just bring it back to the issue of safety versus comfort. And I am not trying to in any way discount the people's past trauma, the extent to which a domestic violence experience can impact someone, and I would not necessarily make the assumption that a transgender person staying in a female dorm increases the danger that other people staying in that dorm experience. I would say that would likely, for some people, increase their level of discomfort. It may mean that they need an additional support, but unless that person has a known history of violence in our shelter against other people they're sharing the dorm with, I wouldn't necessarily jump to the conclusion that they're actually going to present more of a risk than anyone else that's staying in that dorm, I guess is my response. I don't know.
Sir, while I didn't bring up transgender issues, I'd like to add to that. Truthfully, there's more potential risk for the person who, let's say, identifies as a woman to live in a male dorm than the women to be harmed by the transgender woman. And I think that's sort of like the mythology, and I think part of our responsibility is to sort of educate ourselves around some of these issues, but really that is not the concern. If you put someone who identifies another gender with the gender that you think that they should go to based on their biology, you're putting that person at risk.
Yeah, and I would say that of course, there are one-offs in situations where there are people that may use those types of policies for other reasons, but generally speaking, there are not a lot of social benefits to be gained from presenting yourself as a transgender person in our community. Transgender people don't typically have a lot of benefits that are bestowed upon them by identifying that way in terms of how they're treated by the vast majority of society. And so the likelihood of someone falsely portraying themselves in that way just isn't a significant thing that has come up in my experience.
Thank you very much. That's a very comprehensive answer to some tricky questions. So we have a lot of people asking, feeling kind of uncomfortable about this idea of not screening bags or not having a lot of security because of weapons. Someone has brought up, having people who might be struggling with mental health crises, having, quote unquote, a violent encounter, people who might be bringing drugs into the building, and how I know that you've really touched a lot on this, but people are sort of having a lot of anxiety, I think, or concerns. Maybe it sounds like some people who are asking questions have had a bad experience or a dangerous experience, they feel, and they're kind of trying to figure out how to think about security.
Well, I worked in, sorry to jump in, I worked in New York City with kids 13 to 24, and at the agency I worked in, hundreds of kids would come in, and there was never screening, and this issue would always come up around safety. I've worked with folks, my last life, I ran behavioral health programs, and I think there's this fear that people with mental illness are going to be more aggressive and violent, and the truth is that sometimes those aren't the folks that are giving us trouble. I think that sometimes it is scary, but I think it's also changing the culture of the environment, and when you move to less social control and you move to partnership, you get less aggression because the power struggles minimize. When you're in a power struggle and people are frustrated and unheard or angry about something because they're getting triggered by enforcing the rule, which was sort of that question, and if you look at trauma-informed care, control is part of the problem, people escalate. And it is scary. But I think what you have to do, I think what was said earlier about training, staff need to be trained in therapeutic crisis intervention, or CPI, same thing, crisis intervention. People need to know when to call 911. And the truth is, if someone brings drugs on property and I catch you, then I ask you to leave.
Yeah, I mean, I guess with regards to weapons, I mean, that is certainly, you know, a thing that gives me pause. I haven't had a situation where a staff member has been assaulted and actually injured in the time that I've been managing the shelter. It doesn't mean that it couldn't happen, and it doesn't mean that the possibility of knives or other weapons being in the shelter doesn't, you know, give me some level of worry. That said, our mission to our clients, to our community, to that I communicate with my staff, is to try to get as many people indoors as possible. And so I guess, again, I would agree with what Kat said about what is the nature of the relationship between staff and clients. And really what I've found is that in our shelter, even though this is pretty counterintuitive to what happens on the street, we have a pretty good success rate of clients coming to us early on when conflicts are brewing or things aren't going well, and informing staff so that staff can intervene early. And whether that intervention is trying to just verbally de-escalate someone, whether that intervention is calling 911, we tend to have client informants that will come let staff know when something seems to be going sideways, when the situation seems to be escalating, so that we can intervene as early as possible before someone has time to go through in the 6 pockets of their bag and pull out a knife. We already have them at the door, and we're talking to them about what happened, and we're hearing their side of the story before it gets to the point of them using a weapon if they do happen to have one. And so I think that's really the learning to recognize a potential crisis really early on, and setting up an environment where clients are willing to come to staff to report when things are starting to brew, is really one of the keys to helping keep everybody safe.
Thank you. And this is kind of another sort of bringing in drugs question. People want, there's a few questions about if someone brings drugs or illegal items into the shelter, should they simply be disposed of? Should they be, do you have kind of an amnesty box that you let people turn in things to, or and someone is asking, should you call law enforcement?
No, I never call law enforcement. I mean, I think it's pretty flexible to say, I don't care if you get high off campus and you keep your stuff off campus. I think I'm just like everywhere, the crazy opiate problem. It's too easy to sell. And so I ask people not to do it. And if I'm sure that people have drugs. People put things in all sorts of places, but if it's found out, I ask you to leave, and I don't have a struggle with that. Sometimes people have painkillers and they don't turn their painkillers. I'm not going to ask them to leave for that, but if you're selling your opiates, if you're, I've had a person who obviously snuck drugs on. I found him in the bathroom, potentially overdosing, and we called ER, and we didn't let him back in. Partly because we can't respond to those in the same way because of safety issues. And this is not the place to do that,
So our approach is typically, if we encounter someone with an illegal substance, generally that's in the context of them preparing to use in the shelter. Again, we don't search people's belongings, so it happens. People, it's raining outside, they have their stuff with them inside, they're wanting to use whatever substance it is. Our typical response is to give that person a choice between disposing of it. So that would mean dumping out their beer, or putting their sharp in the sharps container, or depending on what it is, giving it to staff for us to have chief staff dispose of. Or they can take that substance out with them for the rest of the day and try again tomorrow. Really the idea being that if we just tell them that's not allowed and then we walk away, they're going to continue doing exactly that thing. So we want to try to, we have a rule against use in the shelter. And so we want to try to encourage that to not happen. That said, we also are serving people that are addicted to substances. And so when they are falling victim to their addiction, putting them outside doesn't seem necessary necessarily, and doesn't seem good for the person. So if we're able to give them that choice of, hey, we did catch you, it's against the rules, but you're welcome to stay. We just can't have you doing that. So we're going to dispose of your substance. So that's our approach.
Thank you very much for sharing that. And I know we're a little bit over time, but I wanted to ask one more question if you both have a couple more minutes. Thank you. There's just so many great questions coming in, and I don't want to lose your expertise while we have you. So there's some folks asking about, and I think this might be for DESC, but also probably Kat, you might have some thoughts on serving really high need people with high medical needs. You know, we hear from a lot of shelters that people come straight from the hospital and they're not equipped to do that, and they're not quite sure, you know, how to approach people who have really high needs, especially who are medically frail. So do you have any kind of thoughts on that?
Sure. So we accept about 10 referrals per day directly from hospitals. Some of those are people that have been seen at the ER. Some have been inpatient. Some are coming from psychiatric hospitalization. We have a series of pre-screening questions that we ask when someone's being referred to us from a hospital to try to gauge whether the level of care that they require is appropriate for the hospital. We interact with the referring social workers that are, I mean, we're lucky enough to live in a large metropolitan area. All the hospitals have social work teams. So I know that everyone's situation might be slightly different in this regard, but we have, you know, we work with the social worker but the kind of quality and experience of those social workers and their familiarity with what we do really varies. So we have a standardized questionnaire that includes things like, does the person require tube feeding? Does the person have a current C. diff, which is a really horrible, I don't know, gastrointestinal, really super contagious disease. And so there's some things that are screen outs because we feel that either presents a significant safety hazard to other people staying in the shelter. Do they have TB? Not going to take them if they have TB. You wouldn't believe the kinds of things people try to get referred to us with. But so we go through that screening questionnaire with the idea of if we can just say no at the point of them still being at the hospital and still being at the point of receiving care, then the social work department has an opportunity to kind of rethink whether discharge to homelessness or discharge to a homeless shelter environment is an appropriate discharge plan. Once the person gets there, then we do try to, or if the person just comes in from the street rather than being referred from a hospital, if we've accepted the referral or if the person comes in, we basically document observations around that person's ability to care for their needs independently. So yeah, I guess that's the big thing. And we work with a lot of people that are right on that borderline, 5 days a week, they're able to care for themselves, they're able to get themselves out of bed and into their wheelchair. And then 1 or 2 days a week, they struggle. And so we have to make a decision about, do we implement a therapeutic bar that will disallow staff from accepting them on a referral or having them stay in the shelter, or do we continue to kind of work with them until it's the reverse and it's 5 days a week that they can't transfer and 2 days that they can? And trying to really take into consideration the limitations that we have with the number of staff and the training that staff have, with the fact that oftentimes if we don't accept the person, they're just going to be either in a different homeless shelter or unsheltered and homeless. So that is definitely a tricky thing, but we don't lift people. That's one of our big lines in the sand that we draw. I mean, we help people up if they fall because they're drunk or whatever, but we don't transfer people from their wheelchair to their bed or to the toilet, and we don't lift people. So
neither do we. I think one of the biggest needs in our community is people with severe healthcare issues. You have to have some capacity to take care. In some instances, we've had folks who've had insurance. We had a man who was over 500 pounds with one leg, and we had nursing come here because we couldn't help them with the ADLs, and they would come and do the ADLs. But that's an exception because most people here in Florida do not have Medicaid. They have healthcare district, which is a whole other thing, but people don't have that resource.
Thank you both so much. I wish I could ask you a million more questions, but I know that you have probably to go, and we've been here and you've given us so much information. I want to thank both of you so much and everyone for listening today. And we're going to post and record the webinar. I'm going to try to take a lot of these questions and, as Ben said earlier, try to put them into kind of a frequently asked question and answer document for folks. Please feel free to keep sending us your questions. We will try to get them answered. If you have questions for Kat or for Liz, we'll get them to them and try to get those answers to you, as well as their rules. We'll try to post those on our site. Our next webinar is in December, and we'll let you know when the date is, but it'll be about evaluating shelter's performance with data. One of the things in your handouts were the shelter metrics, so take a look at those, see if you want to try to implement them, and we'll talk about them next month. Again, thank you so much to Liz and to Kat, and we really appreciate the work that you do and sharing your experience with all of us.
Thank you.
Thanks for having us. Yeah.
Have a great weekend.
All right. Take care, everyone.
Bye.